Let's get right into surgical MCQs, shock, hemorrhage, and transfusion.
Massive transfusion complications. We're doing a rapid clinical review here.
Okay, MCQ 11. A 34-year-old patient receives 10 units of packed red cells within 24 hours following blunt torso trauma. He develops circumoral tingling. What should be administered? Option A, intravenous magnesium sulfate. Option B, platelets. Option C, fresh frozen plasma. Option D, intravenous sodium bicarbonate. Or option E, intravenous 10% calcium gluconate. The correct answer is E. So a massive transfusion of stored blood can actually cause hypocalcemia, and that's because of the citrate present in blood preservatives. That citrate binds ionized calcium, which pulls down serum calcium levels. That circumoral tingling, that's a classic manifestation of hypocalcemia. So the definitive treatment here is IV 10% calcium gluconate.
Let's hit the exam pearls. Massive transfusion is defined as replacing the entire blood volume within 24 hours. Citrate toxicity leads to hypocalcemia, and remember, circumoral tingling is an early sign of that. Treatment for symptomatic hypocalcemia is IV calcium gluconate. Also, massive transfusion can cause hypothermia, coagulopathy, hyperkalemia, and acidosis. Finally, keep in mind that packed RBCs lack factor V and factor VIII. MCQ 12. A polytrauma patient undergoes a laparotomy and receives 10 units of packed red cells. In recovery, he starts bleeding from his IV cannula sites. What's the most appropriate treatment? Option A, whole blood. Option B, fibrinogen concentrate. Option C, fresh frozen plasma. Option D, heparin. Or option E, cryoprecipitate. The answer is C, fresh frozen plasma. Massive transfusion with just packed RBCs dilutes the clotting factors, directly leading to dilutional coagulopathy. Fresh frozen plasma has all the coagulation factors, making it the perfect treatment here. For the exam pearls on this one, packed RBC transfusion alone can definitely cause dilutional coagulopathy. FFP contains all coagulation factors. The standard massive transfusion protocol uses a ratio of packed RBCs to FFP to platelets of roughly 1 to 1 to 1. Platelets are thrown in to prevent thrombocytopenia, and cryoprecipitate is indicated when fibrinogen drops low, specifically under 200 milligrams per deciliter.
Next up, blood loss estimation and hemorrhage classification, clinical measurement and staging. MCQ 13. How can we estimate blood loss in the operating theater? Option A, hemocrit immediately after surgery. Option B, weighing soaked swabs. Option C, looking for a rise in pulse. Option D, collecting blood in a kidney tray. Or option E, none of the above. The correct answer is B. The absolute most practical intraoperative method is weighing surgical swabs in sponges. You just subtract the dry weight from the soaked ones. Since 1 gram is roughly equal to 1 milliliter of blood, it gives you a really accurate estimate of blood loss.
Exam pearls. A 1 gram increase in sponge weight equals roughly 1 milliliter of blood loss. You absolutely must correct blood in suction bottles for any irrigation fluid used. A large laparotomy sponge holds about 100 milliliters of blood, while a small swab holds about 10 to 20 milliliters. And remember, to calculate actual blood loss, you ultimately need hemocrit values. MCQ 16. Which of the following denotes compensation in Class 2 hemorrhage? Option A, increased blood pressure. Option B, increased narrow pulse pressure. Option C, increased heart rate. Option D, normal sympathetic tone. Or option E, none of the above. The answer is C, increased heart rate. Class 2 hemorrhage means a 15 to 30% blood loss, which is roughly 750 to 1500 milliliters. Sympathetic activation steps in quickly to compensate for this volume loss by jacking up the heart rate and inducing peripheral vasoconstriction. Because of this, tachycardia is the very earliest and most reliable compensatory sign. Exam pearls. Class 2 hemorrhage means a 15 to 30% blood loss. Tachycardia, which is a heart rate over 100 beats per minute, is the hallmark compensatory response here. Orthostatic hypotension might happen, and the patient is usually anxious. However, blood pressure is often maintained initially. MCQ 19. A loss of 1,000 milliliters of blood following a penetrating wound falls under Option A, Class 1 hemorrhage. Option B, Class 2 hemorrhage. Option C, Class 3 hemorrhage. Option D, Class 4 hemorrhage. Or Option E, Class 5 hemorrhage. The correct answer is B. Class 2 hemorrhage maps to 750 to 1,500 milliliters of blood loss, so that covers the 15 to 30% window. Therefore, losing 1,000 milliliters puts the patient squarely in Class 2 hemorrhage.
Exam pearls on hemorrhage classes. Class 1 is under 750 milliliters, or less than 15%. Class 2 is 750 to 1,500 milliliters, or 15 to 30%. Class 3 is 1,500 to 2,000 milliliters, making up 30 to 40%. And Class 4 is anything greater than 2,000 milliliters, which is over 40% of total volume. And remember, tachycardia officially begins in Class 2.
MCQ 20. A trauma patient has a blood pressure of 80/60, a pulse of 130 per minute, decreased urine output, and confusion. What is the approximate blood loss? Option A, less than 15%. Option B, 15 to 30%. Option C, 30 to 40%. Option D, greater than 40%. Or option E, none of the above. The answer is C. Look at the presentation: frank hypotension, severe tachycardia over 120 beats per minute, oliguria, and altered mental status. These are the classic, defining features of Class 3 hemorrhage, which directly corresponds to a 30 to 40% blood loss.
Exam pearls. Class 3 hemorrhage is that 30 to 40% blood loss mark. The heart rate will usually be over 120 beats per minute, frank hypotension develops, urine output drops significantly, and mental confusion is very common.
Mechanisms and types of shock, pathophysiology and presentation. MCQ 14. A 34-year-old patient donates 1 pint of blood. He develops thirst and dehydration but has no other complaints. What is the most likely diagnosis? Option A, acute renal failure. Option B, covert compensated hypovolemia. Option C, overt compensated hypovolemia. Option D, moderate shock. Or option E, decompensated shock. The correct answer is B. In covert compensated hypovolemia, the blood pressure remains totally normal because circulation is maintained by the body's built-in compensatory mechanisms. Patients might just get thirsty, drowsy, nauseous, or even have hiccups without any obvious signs of shock.
Exam pearls. In covert compensated hypovolemia, you have normal blood pressure and the earliest symptom is thirst. The body strictly maintains systemic circulation at the expense of splanchnic circulation. Now, in overt compensated hypovolemia, the patient presents with tachycardia and cold, clammy skin. Finally, decompensated shock brings on frank hypotension and outright organ failure.
MCQ 15. In a patient suffering from shock, which mechanism leads to circulatory collapse? Option A, adrenocortical insufficiency. Option B, increased peripheral volume. Option C, less circulatory volume. Option D, failure of sympathetic or vasomotor response. Or option E, none of the above. The answer is D. At first, shock is compensated by sympathetic activation, which causes vasoconstriction to keep vital organs perfused. But when this vasomotor mechanism fails, those compensatory responses literally collapse. This leads to severe hypotension, tissue hypoperfusion, and irreversible shock.
Exam pearls. The failure of the sympathetic vasomotor response is what directly leads to circulatory collapse. Progressive shock is all about continuously worsening tissue hypoperfusion. That forces the body into anaerobic metabolism, causing lactic acidosis. Cellular hypoxia then leads to organ dysfunction. Ultimately, irreversible shock results in multi-organ failure, no matter how much you try to correct hemodynamics. Lactic acidosis is really a true hallmark of progressive shock. MCQ 17. Which is the most common type of shock? Option A, hypovolemic shock. Option B, neurogenic shock. Option C, septic shock. Option D, cardiogenic shock. Or option E, obstructive shock. The correct answer is A. Hypovolemic shock resulting from hemorrhage or fluid loss is absolutely the most common form of shock you'll see across general surgical practice and trauma settings. Exam pearls. Hypovolemic shock is the most common shock overall, and hemorrhage is its most common cause in trauma. The initial treatment is rapid fluid resuscitation. Hemodynamically speaking, cardiac output is decreased, but systemic vascular resistance is markedly increased as the body desperately tries to compensate.
MCQ 18. Which of the following is the most common type of hypovolemic shock? Option A, decompensated shock. Option B, covert compensated hypovolemia. Option C, overt compensated hypovolemia. Option D, moderate shock. Or option E, none of the above. The answer is B. Most patients initially present in the compensated stage, where their blood pressure is maintained despite having a reduced circulating volume. This specific early stage is exactly what we call covert compensated hypovolemia. Exam pearls. Covert compensated hypovolemia is the most common stage you'll encounter. During this stage, blood pressure stays entirely normal. Increased thirst is a primary, very early symptom.
Organ perfusion is preserved by critical redistribution of blood flow. Spotting this stage early is exactly what prevents the progression to overt shock.
So do you know the clinical markers to actively monitor and prevent covert compensated hypovolemia from silently progressing into irreversible shock? Keep that in mind for your clinical practice, and I'll catch you in the next explainer.